Our first presenter, Dr. Riad Elfakih, with the presentation title, Clinical Course and Outcome of COVID-19 in Hematopoietic Stem Cell Transplant Patient, original report from the Middle East. Dr. Riad Elfakih is working as a consultant in hematology, stem cell transplant and cellular therapy, and head of the clinical research department at King Faisal Specialist Hospital and Research Center in Riyadh. He's associate professor of medicine at Al Faisal University. Dr. Riad.
Thank you, Dr. Mohannad. But as you know, COVID is a deadly illness, potentially in some patients, and specifically in cancer patients. And several studies have shown that cancer patients are at a higher risk of morbidity and mortality. So what we've done, we looked at the transplant patients who developed COVID post-transplant, trying to understand the outcome in these patients. So we reached out to the Gulf countries and we collected 91 patients from the Gulf area from 10 centers. So 91 patients were collected, and here we report the outcomes of these patients post-COVID infection. So I hope you can see my slides, and I'm trying to move the slides. Unfortunately, I cannot see the slides from my end, so I'll ask you to move through the slides, okay, if that's okay. So let's move to the third slide. So basically, as I told you, COVID is potentially lethal infection, and especially in patients with cancer. And what we did is trying to study the outcome of patients who had a transplant and developed COVID post-transplant. So it's a retrospective study from 10 transplants across the Middle East. And what we did, we studied the outcomes of these 91 patients who had COVID post-transplant, and the outcomes in terms of how many needed hospital admission and what was their WHO COVID severity stage. And we made a severity composite endpoint, which was consistent of admission to the ICU, the need for oxygen, need for mechanical ventilation, and mortality. So it's a composite endpoint, okay? So three main endpoints: hospital admission, WHO severity, and the composite endpoint. And we studied the impact of different risk factors on these endpoints, and these risk factors that were studied about the correlation with the endpoints were the age, sex, body mass index, presence of comorbidities, type and number of transplant, type and intensity of conditioning, being on immunosuppression, the current status of the underlying disease, the use of prophylactic antimicrobials, and the time from transplant to COVID infection. So again, 91 patients, and the pre-infection characteristics were as follows. The median age was 35. 73% were thin with a BMI less than 30, and 52% did not have comorbidities, okay? Only 16% had multiple comorbidities. The underlying diseases before transplant were 23% benign, 30% leukemia, 29% lymphoma, 18% multiple myeloma. 57% were allotransplanted, 43% were autotransplanted. 89% received myeloablative conditioning, so the majority, and 77% of the conditioning were non-TBI, okay? The median time from transplant to catching the infection was 14.9 months, okay? And 46% of the patients were not on immunosuppression when they catch the infection, okay? So first of all, let me tell you the clinical outcome of these patients. 86% had symptoms, 14% were asymptomatic. The symptoms were pretty much like any viral illness: fever, cough, and shortness of breath. These are the most frequent symptoms. 58% of the infected patients had abnormal chest X-ray, and 13% had elevated white count. 3% had elevated lymphocyte count, 52% had reduced lymphocyte count. This is when they were admitted with the infection. The neutrophil count was high in 13% of the patient. Platelets were low in 45%. Ferritin was high in 67% of the patients. Sedimentation rate was high in 75%, CRP in 87%, and the albumin was low in 77% of these patients. The outcomes. So 50% of these 91 patients had mild COVID-19 stage per the WHO staging criteria. 53% were admitted to the hospital. 14% needed ICU admission. 10% needed mechanical ventilation. 18% needed oxygen. 4 patients died, constituting 4.4% of the total population. Okay. Of these patients, we had follow-up swabs, nasopharyngeal swabs, and 77% of them cleared the infection at a median time of 34 days. And of these patients also, we had follow-up antibody testing, and 67% of the tested patient tested positive. So we're able to mount antiviral antibodies. Acute kidney injury happened in 10%, was reversible. Thrombosis was only in 1 patient, and it was line associated. So as far as the correlation of the risk factors with these outcomes, the time from transplant to COVID infection, more than 6 months. So patients who were transplanted more than 6 months, and then they catch the infection, had a lower admission rate of 74% as compared to 45% to the others, okay? And had a lower rate of severity composite endpoint, 35% versus 16%. Okay, patients who were not on prophylactic antibiotics, okay, before the infection, had higher admission rate. For the subgroup of the admitted patient, high neutrophil count was associated with higher need of mechanical ventilation, and males required more ICU admission. And again, 2/3 of the patients were able to mount an antibody response, and 77% cleared the infection by PCR testing. So we report favorable outcome of our patient, okay? Our mortality was only 4.4%, okay? And our interpretation is that our population had a younger age and less comorbidities as compared to the reported cohort from the West. All our patients were treated in tertiary care centers, while the patients reported from the West were in different centers because the healthcare system was overwhelmed. And in line with other reports, we show that the mortality in transplant patients is lower than patients with hematologic malignancy and lower than patients with solid organ transplant. And our interpretation was patients who undergo transplant are selected. Okay, so this is positive selection of fit and young patients. And the other thing is the theoretical lower intensity of lung inflammation from an impaired immune system in the post-transplant. So lung inflammation was less in these patients, and as such, the mortality was lower. I'd like to thank the patients and the families, the SSBD for the administrative support, and all the colleagues who shared their patients and their patients' outcome across the Middle East. With that, I will finish, and thank you so much.